Good afternoon, everyone. I hope you can all hear me and see me. Welcome to the Cambridge Centre for Health Services Research 2021 Annual Lecture. Just to introduce myself, I'm John Sussex. I'm a Senior Health Services Researcher around Europe, and I co-direct the Cambridge Centre for Health Services Research with Steve Morris. Steve will be taking an active part in this later on. And we are both very, very pleased that we were able to persuade Dr Charlotte Augst, Chief Executive of National Voices, to present this year's annual lecture. And she's talking on the topic of universal NHS healthcare. Has the pandemic changed the promise? And I guess most people on this, watching this now, will have their own views of the answer to that question. But we're going to hear Charlotte's first. But first of all, a little bit of housekeeping, and then I'll introduce Charlotte properly. The housekeeping is that we are recording the proceedings. Hopefully you've all seen that on your screens. And secondly, we'd very much like you to ask questions of Charlotte, and to do so at any point during the proceedings. But to do that, please use the Q&A. We've disabled the chat button, but the Q&A is working. So please type your questions in there. And then after Charlotte has presented her lecture, Steve Morris will be chairing a session of questions and answers. We promise to finish promptly by 1:30, so you will get away on time. So Charlotte, I just want to say a little bit about Charlotte, because we are actually, as I said, extremely pleased that she's here to talk to us all today. She's been in the UK quite a long time and has been a very active worker in the field of health and social care policy through that time, for Parliament, for regulators, and for the charitable sector. And it's kind of in the charitable sector now where she has a very high profile as Chief Executive of National Voices. I guess most of you will know that National Voices is a charity, and that it represents, if you like, the one of the many people who represent, but at a high level, the voice of the users of health and social care. So she's presenting, I'm going to put it, the point of view of the punter. And in my view, she has a very strong and very clear voice and opinion to be heard on very important matters, which you're about to find out. And I just wanted to add, because this is her own word and it struck me very home, and I've seen her and heard her use it before. She has, she says, a very strong aversion to her word, bullshit. So let's judge for ourselves in the following. And Charlotte, over to you. Thank you.
Okay, well, you've just raised the stakes. Thank you, John. And everybody on the call can obviously judge whether I stick by my rule that we should try to reduce the amount of BS we indulge in health policy making. I am going to try to share my screen, which we did succeed to do earlier. And is that working for everyone? I'm not hearing anything else, and I can't see anyone. It's one of those disconcerting situations. I just want to say thank you before I start. Thank you to everyone on the team, KG, Steve, Lynn, and thank you in particular, John, who I think might have had the idea to invite me. I feel really quite intimidated, I have to say, given the kind of people who normally give this lecture. John has already introduced National Voices. We're an umbrella organisation, if you want to call us that. We've got about 190 members. The numbers are going up, which is obviously hugely satisfying. Health and care charities in England. We have all the really large players that you will have heard of, maybe even ran a marathon for at one point in your life. And loads of smaller ones you will maybe only have heard of if you have reason to worry about a particular condition, maybe someone in your family. And then we also have a lot who are sort of about particular cohorts of people, focused maybe on an inequalities aspect. In one way of looking at us is that we're sort of like a collective policy and influencing team for the wider charity sector in health and care. Obviously, the very large charities, Macmillan Cancer Support and the Alzheimer's Society and so on, they have very large influencing teams themselves, but they're kind of outliers in the sector. Most charities don't even have paid employees, but even the ones who don't start with a policy team, they start with services. And so for the smaller ones, and even for the medium-sized ones, we sort of act as their collective policy and influencer team, if you want to describe it like that. And for the larger ones, I think we complement their work. We look at the cross-cutting themes, the issues that a lot of people have in common, regardless of whether they have heart failure or COPD or depression or sore knees. Things like care coordination, carer support, emotional support, prevention. Those sorts of themes are the stuff that keep us busy. I thought I'd say a few words about myself because I'm probably new to most of you. I don't have at all a handle as to who's in the audience. We shared it obviously in our networks, but I think it's mostly the Cambridge and the more medical end of things. So I just thought I'd say very briefly a few words about myself so that you can locate where my voice is coming from. I graduated with law, and I don't quite still understand how that happened because can't really see myself as a lawyer, but I've got quite a working class background, and I think that's what you do. You do a profession when you go to uni. When you're the first generation to go to uni, you don't do sociology. So I ended up doing law, and I came here in 1997 for postgraduate studies, just after Princess Diana died. I remember it clearly. And I ended up drifting into sort of a medical ethics department where I did a PhD. And I have worked in health and care policy, science policy ever since. I've got 2 teenagers, and my husband David died in 2018, which I think shapes some of my thinking about health and care service use, because it was obviously preceded by a number of years of very intensive use of health and care services. And I started at National Voices in 2019. So in the spring next year, I will have done the job for 3 years. And one thing I did was I refocused the organisation maybe much more on the experience of people who use health and services very regularly, or maybe should use health and care services regularly to have a better life. When you look at people's actual experience, when you try to understand what goes on for people, you realize very quickly what goes on for people is very unequal, and that it's not random as to whether you have a good experience or a bad experience. There's an element of randomness, like the receptionist in your GP surgery might be lovely, or a dragon, that's a bit random, but there is obviously very clear patterns underlying whether you have good access, a good experience, and good outcomes of healthcare use, and that should be a cause of concern for all of us. So I'll talk about that a bit because it's obviously a direct challenge to the concept of universality. Before I get going properly, I just thought I bring the voice in of someone who's even less likely than me to be at an event like this today. I realise I'm a bit of an outlier maybe in the usual kind of cohort of people who do these sorts of lectures. I'm not a medic, and I am not at the helm of a very large administration or a very prestigious institution, which seems to be the kind of people who you normally have giving these lectures. And I do think sometimes when you are getting through a door, maybe for the first time, it's important to keep it open, to hold it open for the people who might just as well slip in behind you. So I am going to try with the next 30 minutes or so to bring in some of the voices of the people you don't tend to hear on the podium at Christmas lectures or end of year lectures. And this just strikes me as the sort of stuff we hear a lot at National Voices. This is very strong language. I feel worthless. I feel like I've been thrown in the dustbin. And it's the sort of stuff we end up holding quite a lot of. And our members even more so, because they run helplines and peer support groups and do outreach. And this is how a lot of people feel as patients. Now is the right time at this point of the lecture, and I hope I'll remember to say it a couple of more times all the way through, that what I'm going to say is not a criticism of hardworking healthcare professionals. I think we're all intelligent people. We can hold more than one thought in our head, and it's entirely possible to hold the 2 thoughts in our heads, that healthcare professionals work as hard as they can and try to do their best job, and that people do not get what they need. It's possible to hold those 2 thoughts. And I think another 2 thoughts that it's possible to hold is some people, a lot of people, get good service out of the NHS. Some people, a lot of people don't. And I think that's a tension that kind of goes to the heart of what we mean by universalism. And I'm going to unpack that, or I'm going to try to unpack that in the following discussion. I'm not a native speaker, you might have picked that up by now. So for years, I had a little dictionary lying next to my bed. Whenever I read a book, I would go, what does that mean? And I would check it. For years, I did that. So I've learned thousands of words from just flicking through my dictionary. So I do that sometimes when I need to think through a topic. I go back to my dictionary. So this is the definition of universalism. And don't know how much further it takes us in discussing it in the NHS context. The way I read those two layers of definition is that it means the NHS as a universal service makes an offer that is the same for everyone. And in England, I think that implies a very strong emphasis that this is regardless of the ability to pay. And that's why we always juxtapose the NHS with the American healthcare system, even though the American healthcare system is actually the outlier, not the English one, because everywhere in Europe, more or less, around the margins, people can use healthcare, even if they're not well off. I think it also implies a comprehensive service, that there is an offer for all aspects of health and illness. And I'm not going to today major, it would be very cheap to major on dentistry and, I'm not going to go there, we all know that. But I'm going to think a bit about what does it mean to provide a service that is an offer for all aspects of health or illness. And I think it implies a very strong promise of equality and dignity, really. There is something very profound in saying that a baby born with a hole in her heart deserves the same care whether she's born to a recently arrived Syrian refugee or to someone who resides in a palace in Westminster. I think that's something that it implies a very profound statement about human life. So I am going to try to unpack the question of universality on 3 levels. I'm going to try to say a few things about equality. I'm going to try to say a few things about holistic care, the idea of comprehensive service. And then I'm going to say something about whether this implies also a degree of overstretch, that universalism means because we're going to look after all of health as the NHS, we somehow own all of someone's problem. And that we confuse medicine with cure, or we confuse healthcare with health. So, first up, equality. I'm assuming you're all a very expert audience. I'm assuming that you know the numbers, so I'm not going to go through the numbers. I've just brought the voice of someone who spoke very eloquently at a conference we organised at National Voices that looked in detail at health inequalities, and this was one of the days we looked at racism. And this is a young woman who can, in her lifetime, describe 2 very profound experiences of health inequality. I'm sure she could describe even more, but these are 2 that resonate very much with the national numbers. One is a maternity one, where she describes how her mother was treated, and one is a mental health one, where she describes how she herself was treated. Now, I'm also, as well as assuming you're all really expert, I also assume that you're all good people. The NHS, the health and care system, people who think about health and care, are not people who want these sorts of outcomes to happen. You do not want Black women to be 4 times more likely to die in childcare. You do not want young Black men to be totally overrepresented in the most repressive aspects of mental health institutions. You do not want poorer people to have much worse outcomes around their asthma, their diabetes, their COPD. That's not why any of us get out of bed. So how come a whole load of good people wanting to deliver healthcare that's very explicitly set up with the aim of creating equality end up delivering these kinds of outcomes? And And in thinking this through, two images came to my mind. On the left, at least for me, I don't know, I'm finding this confusing, you can see a conveyor belt, a factory. And on the right, a sort of workshop. I do think, as good people, have sometimes responded to the challenge of inequality by saying we need to make healthcare more like industry, like factory. We need to deliver the same maternity care to white and black women. We need to deliver the same indistinguishable healthcare, mental health care for white men and black men. We need to offer the same support to poorer and richer people with asthma or with diabetes. And I sometimes think this desire to take out bias, this desire to reduce decision-making spaces that would allow discrimination to creep in, has led to us conceptualizing healthcare as if it's a process that runs down a conveyor belt. Now, the people who work on this conveyor belt have a very precisely defined job. I don't actually know what they're making there, but the guy with the hairnet, he will do the same thing over and over. He can't do any of the other things. He's not responsible for the whole. He's doing that one thing. And if you're the patient traveling down that conveyor belt, which a lot of people experience because they need more than one thing doing, then you need everybody to know exactly what they're doing at exactly the right time. The thing needs to move at exactly the right pace. Otherwise, the wheels very seriously do come off very quickly. One thing that really strikes me when I see that picture is work as done needs to be exactly the same as work as imagined, to quote Alison Leary's concept. The person who designs this conveyor belt needs to be really confident that the way the people are going to deliver the work is exactly the way they've envisaged it. Now, we all know that this is just not how healthcare works. We all know, especially now, there's loads of dead ends in there. There's loads of bits missing. There's loads of corners where the parcels moving down this conveyor belt are going to fall off, are going to move into a dead end, are going to get stuck. It's of very limited use to then have a bunch of healthcare workers stand around that conveyor belt going, I only know how to put the eggs in the box. I only know how to close the lid on that box. I only know how to put the box in a bigger box. That's my job. Doesn't work. I think a healthcare system under strain that has configured itself like a conveyor belt delivers shockingly poor care to people. The majority of people who use healthcare have complicated problems. Where this conveyor belt model works is for a vaccination program, let's say. And even there, it only works for people who are average. Doesn't work for people who might have autism or don't speak English or have a learning disability or a needle phobia. But, you know, putting a jab in someone's arm and being done with it is just about the level of complexity where this model might still work. And also it might be where the patient's actually quite happy to receive care in that way. In, out, done. The majority of healthcare isn't like that. The majority of healthcare use isn't like that. So if you have dementia and depression and sore knees and breathlessness, this model is absolutely hopeless. What you might have a longing for, and I sometimes feel like that when we listen to people in our insight work, is that other picture. You'd like to meet a craftsman. You would like to meet someone who says, all right then, what have we got in front of us here? What tools do I need? I've got all the tools at my disposal. It's my discretion how I bring them into play. And I will tend to this problem until I feel like I've fixed it in as much as it's fixable. And I know what a lot of you are going to think, you know, I'm a GP. I'm a cardiologist, I'm a diabetologist. The people we deal with, I cannot know everything. If I'm a diabetologist, I cannot know about their needs. I cannot know about their depression. And that's probably true. But I don't know whether you know this television program where people come with their little antique thing and they have it fixed. And sometimes they need someone who can do a bit of upholstery, and they also need someone who can, you know, do the woodwork, and then they need someone who knows how to do a staple. And they take, you know, the craftsperson takes this thing to someone else and says, I don't know how to do this, but could you do this? But it's very obvious that it's their armchair they're fixing, and that they are the ones who are going to make sure that the person who gave them that, whatever, heirloom wants a nice armchair back. And I do think, listening to people, I do wonder whether this is what quite a few of them have a longing for. They'd quite like to meet that person who isn't just putting the eggs in the box, but actually looks after the whole. I don't know whether that's the answer, but I think it's a question worth thinking about, whether in our desire to make healthcare more equal, we have actually made it more industrial. The second question I wanted to unpack was, and it's obviously related, all these concepts are related, is that universalism implies a degree of holistic support. It implies that all your healthcare needs will be taken care of. And again, I've just brought some words along from people who are a long way from this particular lecture theatre. So when universalism is understood as holistic and looking after all your needs, now this person was told having dementia does not matter. That can't be true in a healthcare context. That is a statement that undermines completely the value of the care that will now be delivered. The first statement is just the usual muddle of organizing a process so that your needs can be looked at in the round. I was thinking how, you know, with this conveyor belt, can I find an image online of a really rickety factory where all the wheels are coming off and all the parcels are falling off the conveyor belt? But then I was in a meeting with one of our members, James Watson O'Neill, who runs an organization called Sign Health. Sign Health is a charity that looks after the health needs of people who use British Sign Language. And he said, healthcare feels like you're at the last stage of the Game of Thrones. There's people who die trying to get over that wall. And he said, people are dying. And it was one of those moments in a meeting full of polite academics and doctors that happened to be Oxford, not Cambridge, that caused a moment of silence. Because he knows what he's talking about when he talks about the healthcare needs of deaf people. And when you think about how that all panned out during the pandemic and how we still not reliably seem to be able to put interpreters alongside healthcare announcements, it's really quite astonishing. Now, I've never watched an episode of Game of Thrones, but I just think it's quite a striking image. And it takes me to the question of access, which is implied in the question of holistic support. Again, two voices, two different people who spoke to us when we looked at the critical role of admin for healthcare. And I chose those two because we sometimes think access, there's new sexy barriers to access who are digital exclusion. And then you hear people talk and it's like, it's good old-fashioned exclusion. It's not sexy new digital exclusion. We have both going on at the same time. There is a time slot, you can't meet it, it's all that. But there's also obviously not catering for people who do not know how to use an iPad. And then there's COVID. So I think we would be kidding ourselves if we thought COVID hasn't made all of this a whole lot worse. And again, and I feel this is another opportune time for me to say, I'm not criticizing hardworking healthcare professionals who have given their very best and sometimes even their lives during these last 20 months. And many of you will feel the tiredness in your bones and wonder whether you'll ever feel well again. So I'm just saying, this has become a massive problem for people. People feel locked out of the NHS, particularly people living with chronic ill health. So this led me to write a little column for Health Service Journal, as you do. And that's, I think, why John thought I should maybe come talk to you today. So the question I'm sort of asking in this Health Service Journal column is, are we witnessing the collapse of universal healthcare? But maybe more importantly, would we even recognize it if we saw it? Or is our mental model of what the collapse of universal healthcare looks like the wrong one? Do we apply the mental model of Woolworth? Woolworth closed down from a Tuesday to a Wednesday because the banks pulled the plugs, the shutters went down, that was it. I do not believe this is what the collapse of universal healthcare looks like. And I'm reminded of Trish Greenhalgh, who I think is also given the lecture here, who's every year posts a blog she's written about what it looks like when someone drowns. Again, where our mental model is wrong, and therefore we don't recognize when people are drowning, because they drown very quietly. It's worth reading. Again, I don't know the answer. My hunch is we wouldn't see it when universal healthcare collapses, because we're looking for the wrong picture in our minds. I want to make the third layer of what I think universalism might be or not be in healthcare, by looking at the sort of overpromise of medicine that we sometimes witness. If medicine is, if the healthcare system on offer is universal, does that imply that health is all there is? That medicine needs to be all there is? That healthcare is the same thing as health? That delivering effective healthcare intervention is the same as living well with a long-term condition? That the interaction with the healthcare service is the same as having a good life? Clearly it's not. And these two people talk about what that could feel like if the system, if the person providing the healthcare blunders on, seemingly unaware that the person who's just been diagnosed with a condition will need to live 99.9% of their time outside of healthcare setting, and that the outcomes for, let's say, diabetes, like here, depend to 99.9% on the person doing that bit well. That is where actual healthcare happens, not in that consultancy room primarily. So if healthcare assumes that it's everything, it misses a huge amount of what's needed to do healthcare well. I want to move into the final stage of my presentation. I'm sure you want to also come out and say some stuff. I'm going to propose 3 thoughts, maybe rules. I mean, rules is a strong word, isn't it? 3 ideas for what a realistic universalism might look like. The first one is health is more than healthcare. Second one is one size does not fit all. In fact, one size fits very few people. And the third one is the quote that I use a lot, and it's apparently very contested who said it. Some people say it was Hippocrates, and some people say it was some American philosopher, I don't know. Anyway, it's a sensible quote, isn't it? Cure sometimes, relief often, care always. So, first of all, health beyond healthcare. We've already touched on that in our diabetes example. Here is an example one of our members, Rethink Mental Illness, shared with me. Some really good work they're doing in the southwest of England around giving people budgets and coordinated care around them. And here's what someone did with their budget. They invested in a personal trainer, and they're waiting for a dog, and they feel very much like they're having a much better quality of life. If you look at that report, the kind of person who's lives with severe and enduring mental ill health and has used mental health services for many, many years has used up a huge amount of healthcare resource, very expensive healthcare resource, and has on the whole often achieved very little quality of life with all of that. And unlocking some of this, for example, through giving people a personal budget, even if the Daily Mail thinks that's wasteful, can really make sense of the fact that health is so much more than healthcare. The second idea for a more realistic universalism is that one size truly does not fit all. So this is research our members Independent Age shared with us, and it's to do with older people's mental health experiences. And they hear very strongly that these older people feel like they're just being forced, not all of them obviously, but some of them feel forced into just taking a tablet, that they're being shrugged off the healthcare system, the conversation they want to have with their GP or their nurse. Oh, just go on antidepressants. And it's not what they want, and it's not what they feel will add to their lives. And these two people we hear from here are talking about experiences of bereavement. And it makes me also again think about the earlier argument I tried to make about the kind of medical overstretch. By which stretch of which imagination is it a sign of illness to be sad when your long-term partner dies when you're old? I just think that's a weird idea, really, isn't it? So I do think a more realistic universalism would very much start from the assumption that we're not all the same and that our experiences are manifold, and therefore our responses need to be much more personalized. Finally, the idea that you cannot cure or even treat everything, but you can certainly care. That's something we hear a lot when we speak to people. Here is some research we did at National Voices about the emotional support needs people have when they have a physical health condition. And there is a positive experience there and a couple that are not so positive. When I get to this kind of argument, I always worry that people think kindness, which is essentially what we're arguing for, is this sort of cuddly add-on. It's like a cop-out to say to an overstretched, totally pressurized healthcare system, couldn't you just be a bit kinder? And I'm always reminded of Julia Unwin's work, who's shown so clearly that kindness is not an additional thing we can demand of people who work in systems that are designed for a lack of kindness. Kindness needs to be built into the brick and mortar of hospitals and GP surgeries. It needs to be built into accounts and balance sheets. It needs to be built into recruitment and training and incentives. And it's the business. It's not an additional thing. There is strong evidence that living with a long-term condition, or with a number of long-term conditions, especially if they fluctuate, can impose a huge amount of pressure on people's lives. And it's when that pressure becomes too much, they reach out for healthcare. And there's strong evidence that the conversation partner they then talk to, acknowledging what's going on, making themselves available to listen, and not minimizing the strain of managing long-term conditions or looking after someone with long-term conditions helps people cope in and of itself. So I just wonder what healthcare would look like, particularly for people who are chronically ill, if we said the first and most important experience people need to have here, the first and most important outcome we're trying to work towards, is that people come out of this conversation feeling like we've lightened their load a bit. I think we would organize universal healthcare somewhat differently. So, given I'm the headline speaker, I thought I'll take the liberty of inventing one final rule, and that's never ever gaslight people. And again, I went to my dictionary and I checked what gaslighting actually means. And it so resonates with what people tell us about what it can feel like to use a healthcare system that feels it can't meet all your needs and therefore responds by telling you that you don't have those needs in the first place. And it reminds me also of the very first quote I started with at the start of my lecture, of someone saying, I feel worthless and I've been thrown into the dustbin, because I think that is the consequence of gaslighting, which is why abusers indulge in it. And I do think, and that's my final point, I do witness gaslighting. And I wonder whether you, if you work in healthcare services, also witness it, because I do think the Secretary of State right now, standing up in front of people and saying the pressures on the NHS are sustainable, to me that sounds like gaslighting, all of you working in health and care. I also think when a BBC journalist speculates about whether ambulance services will cope through the winter, is gaslighting us, because ambulance services are not coping and haven't coped for quite some while. When we're being promised world-beating cancer services, I feel gaslit. And I wonder whether you working in these services feel like that too. But I think given my role and the purpose of this lecture, telling people they're not depressed enough, not anorexic enough, not immobilized enough, not blind enough to merit support, I think, is gaslighting people. And we shouldn't be doing that. I'll stop there. I did a one-to-one with one of my senior team members yesterday. We talked about a really exciting coaching model we're developing at National Voices. And she quoted something to me she called living leadership, which is a model she's trying to apply to the work we're doing with people who've got lived experience of using health and care services. And there's 3 tenets to living leadership. It's get real, get connected, get help. So zooming right out, I would have thought that's a good way for us together, patients and people working in health and care services, could go. Get real, get connected, get help. Right, I will stop sharing and hand over to my colleague Steve.
Thank you very much, Charlotte. That was a really interesting and thought-provoking talk on your views on universalism, what it might mean and what it doesn't mean. Thank you very much. So we have, and welcome to all participants today from me. So we have around about 15-20 minutes left for some questions, and we have a few coming in from colleagues. So please do ask more further questions in the Q&A if you have one. So first, a question from Alison Powell, thank you for this, about how we might, well, in Alison's words, buttress the service against malicious critiques of the NHS, but acknowledging at the same time that there is a need for more resources, creativity, better political commitment, etc. So any thoughts about that, Charlotte?
I actually interviewed people for head of policy position at National Voices on Monday, because my head of policy is going on maternity leave, and I asked them that very question. I basically said, is the NHS broken, and do we need to say that as National Voices? And all all 5 candidates said no, the NHS is not broken, and no national voices should not say that. And they gave very passionate kind of defense of what a wonderful system the NHS is and how committed it is to equality and dignity and humanity. I came away from that feeling a little bit like, I don't know, why am I not wholeheartedly convinced? I take your point, Alison, that there are people who would like to break the NHS. I'm not personally sure that this is our government, because what a headache would that be. I do think a lot of what I'm talking about can be explained by a lack of investment and a lack of workforce and a lack of resource and old-fashioned capital and, you know, all that. I don't think all of it can be. I think the experience of people, for example, who get harmed in healthcare, which is a certain proportion of people, there's no beating about the bush. Some people get harmed using healthcare. The experiences of those people when they go to health and care service providers and say, I think I got harmed here, or my son or my husband got harmed here, it's just shocking. It is just unbelievable. The systematic response to that raising a concern is denial, gaslighting, undermining, obfuscating, hiding evidence. That is the norm. This is what happens. This is why we have inquiry after inquiry after inquiry. And I don't think that can be explained with a lack of resource. So I do think there's something not right about how we configure this glorious model of healthcare. There's something about the medical model that makes it very hard for the people delivering it to hear where they're going wrong. And I do think we need to unpack that. I don't need to unpack that with Sajid Javid, but I think we amongst us, we need to unpack that.
Thank you very much. So there are a few questions that have come in which are all on a similar theme, which is about, okay, so what can we do? What are the next steps? What should we be aiming to do? So, for example, Lisa Hinton, thank you very much, asking about how do we hear the voices of drowning patients or people who aren't accessing the care that they need, or a question from Sarah Mystery, great question, about what would we ask of our political leaders to do to try and address some of the issues that you've written, and a comment from Ollie about what might someone working in the health service actually do to try and address some of the questions. So maybe some thoughts about how to address some of the issues that you've raised, please.
Yeah, I hope I sort of hinted at a bit of that in my talk. I didn't just describe some of the misery of it. I do think looking at work as it's done rather than at work as it's imagined is really important. And that includes the sort of, you know, when you refer a patient, when you say to a mentally distressed patient in primary care, here is a number for the mental health hotline. Have you checked what work is like as it's done rather than as it's imagined? I think this is something everyone can do, because one of the things that happens all the time is that the person calls the mental health hotline and gets told to call their GP, and the GP says you need to call the mental health hotline, and you know, and so on. Replicate 111, GP, you know, test first, appointment first. Have you actually bothered checking whether this referral leads to a dead end? Have you actually bothered checking what the opening hours of the service are? Have you actually bothered checking that this patient qualifies for the support you imagine they will get? So I think not believing the propaganda we tell ourselves about how the NHS works, because it doesn't work like that. And being much more conservative in assessing what support's actually available. Will you be successful at the weekend trying to call this out of hours community nursing service? Will that work? Will someone come in a timely manner? If not, let's make a more conservative plan. I think that is really important. That would be one thing in my mind. And the second one, I think that we hear over and over and over again, is good communication. That I think is obviously not free, but not expensive. And that people are so forgiving of having to wait a long time, or not being able to get what they think they need, if it's explained well, if it's communicated well, if communication is ongoing, if they're reassured that they're still your patient, that you still care about them, that you might not be able to give them that thing that they're waiting for, but you haven't forgotten about them and they certainly still matter. I think that is something that all of us can do.
Okay, thank you. And then a more specific question, though, still very important one from Mary Dixon Woods. Thank you, Mary, about the pressures facing NHS staff, which are partly due to lack of investment, but also that can have several different detrimental effects. So is there anything that can be done right now to help NHS staff?
I think that's a really, really profound insight we need to act on. I think a lot of lack of kindness and perceived lack of care comes from people being exhausted with the expectation that they should be able to help and they feel very much they can't. I remember when I went to hospital the many times when my husband David was ill with cancer, thinking how lovely the taxi drivers sometimes were. And, you know, David would throw up in the back of taxis and all sorts, but cab drivers were like, okay, we're going to the cancer centre, we're coming from the cancer centre, there's obviously a reason for this, and being really kind and thinking, why can't the bloody people in this building not be kind? You know, and I do think the difference is that the taxi driver doesn't put it on himself that he should be able to sort it, and therefore it's easy. You know, or I remember the hairdresser, David's hairdresser being absolutely lovely, and really, and saying all the right things that no one in the cancer service ever bothered saying. And I do think that really deserves some attention. Why is it that people become hard when they chose to look after people at their most vulnerable? And I do think, you know, our members at National Voices, the Point of Care Foundation, they have a really thoughtful program around that, the Schwartz Centre around, all the support around enabling healthcare staff to remain soft, to remain open, and to not, in a way, shoulder the impossible. I think if you shoulder the impossible, you have to almost like stop going alongside the patient. Whereas if you basically say, a lot of what you deserve is unavailable to us, what could I do for you right now? Human kindness becomes possible again. But again, it requires an acknowledgement that it's no good just throwing a phantom referral at someone when you know that nothing will happen for 24 months. You know, you have to kind of say, yeah, you do deserve better. You do deserve a referral into eating disorder services. You do, you know, but I can't make that happen. It's not going to deliver anything. I'll stay alongside you.
Okay, thank you very much. Slightly different question now from Gordon Gregory. Thank you, Gordon, who is asking about wondering about the merits of privatisation, whether that's a path that ought to be explicitly taken by the UK, for example, in terms of the making the point that private companies might be better than the state at offering this less kind of industrialised service that you were talking about before.
I mean, you want to have that argument with Alison, really, don't you? I think we're confused what we mean by privatising services. Is this about the ownership of the service, or is this about charging people for it? And I think I would never, ever, ever argue that it's okay to charge people for health service use, and that people who, you know, that obviously the person just coming off that little boat in the channel deserves the best possible healthcare because we're people and we all deserve it. I'm much more neutral about who owns the hospital building or who owns the CT scan in it. I think I'm not enough of a Marxist to think that explains everything, and that everything else follows from that question of ownership. I think there's something about the kind of iconic status of the NHS that is afforded by it being under direct government control that has got in the way of being practical about resolving some of its problems. So the politicization of the NHS, I think, has got in the way of treating some of the things that need to be resolved just as practical problems that need resolving. A shared care record, you know, that is not, it can't be beyond the wits of man to pull that off. But I sometimes think because it's been pulled into this political vortex, we almost expect the solutions to come from down from on high. And I think that's disabled and that's disempowered leaders in the healthcare system. And maybe a system that's much more at arm's length from central government, like, let's say, the German system, although I think there's obviously huge inefficiencies in the healthcare system in Germany and huge inequalities, can get on with it more, can just say, why don't we create a shared care record around here, you know, because that will really cut a lot of inefficiencies. So, yeah, that's not the answer you wanted, I'm sure. But anyway, my thoughts.
Okay, thanks. So moving on to a specific question from Chris Larkin asking about the introduction of integrated care systems in England. Just your thoughts on whether that might address some of the problems that you were talking about in terms of equality, holistic care, and access.
Lovely to see your name, Chris. Chris and I have go back a long way. Chris is at Alzheimer's Society now. I think the track record of structural reorganizations leading to different outcomes for people is pitiful. I think the theory of change that would lead from an integrated care board being created and an integrated care partnership being created and this and that being created to someone with dementia and depression and sore knees and breathlessness receiving different care is a very, very long chain theory of change, which breaks at just about every single point when you challenge it. So I am personally a little bit skeptical that this will deliver the desired outcome because none of the other restructures and reorganizations have. There are obviously people who get on with it. They get on with actually coordinating services around people and communities. And maybe they get given more freedom in this new setup and the expectation that this is what should happen is maybe more explicit. But I always think it's going to deliver better outcomes for people if we start with that person with her full needs and we get the people around her who need to talk to each other and share a care record and information and handovers. And then we, at a final stage, say who needs to sit on which board and who needs to, how does the money need to flow? I think if you start with that, it never trickles down. It's like neoliberal economic theory. The better outcomes do not trickle down.
Okay, thanks. Very sobering. So a few comments about the role of community. So first, a few questions or observations from Maggie Gilbert. Thank you about saying how great and important the community is part of the answer maybe, and how to encourage and facilitate that. And do you think that is part of the solution? And then Martin Rowland asks, again, thanks Martin, about making the point that one of the reasons why the NHS has survived for so long and so well is because of the support it has from the public. And do you think that's changing? So kind of a couple of thoughts about the role of the public and community.
Yes, Maggie, and hi Maggie, nice to see you as well. I do think community is the answer. I don't know whether you're on Twitter, but today Samira Ben Omar is celebrating 10 years of community connectors in North West London, and she said community is the present, community is the future. That was her tweet this morning. Beautiful pictures of very diverse communities coming together in North West London. I do think part of the reason we're not reaching people with the current model is that we do not work with the communities who know what the problems are and also have a strong sense of what the solutions could be. The vaccination program was an example of the behemoth that's the NHS and the vaccination program, understanding it needs to partner up with the micro organizations and that person who drives the minibus for the mosque and that person who does the lunch club for Caribbean elders, and that is how we will get the vaccine to people. And the other things we need to get to people are much more complicated than a vaccine, and we need to work with community. I think that is definitely the answer. On the public support, I I do think we see a shift, and I think, you know, picking up Alison's point from the start, that is really worrying. If the public becomes convinced that the NHS just constantly asks for more money and never delivers better experiences for them, I think the NHS will lose public support. And I do wonder whether that is partly the narrative that the investment that the NHS has been given for this winter is meant to foster. The NHS has been given its money to shorten waiting lists and to provide access to primary care. If there's still no good access to primary care, the waiting lists are still not shrinking, it's obviously the NHS's fault and its incompetency of managers and GPs seem to get it in the neck very badly right now. So I do think that is a dangerous situation to be in. We hear very strongly from people when we speak to them a massive gratitude towards the NHS and a very deep understanding of the pressures people are under. But that is not something that I think you can just bank on forever. I think we are seeing that shifting right now.
Thank you very much. I think probably time for maybe one question. Actually, I think this is a theme coming through from a few people. So first, so Eve has made an observation about what you were suggesting about the kind of holistic care that might put a lot of pressure onto health services staff, and maybe there's a scope for enlisting people from other elements of the public sector to try and help fill some of the gaps. And then so any observations about that? And then Simon Griffin, thanks Simon, making the point about how the role of doctors and nurses, they're drowning as well under the current circumstances. So there's a few things, maybe that's some of the implications for some of the suggestions you're making. So any observations about that, please?
Yeah, I think, and I meant to say that, but I must have forgotten to say it. In this sort of argument I was trying to make, that I think there's sometimes a medical overreach, that all of someone's problem becomes the NHS's problem. We need to sort of cut that back and say the medical system can only ever be part of an ecosystem of support. And we are in deep trouble if we try to resolve poverty and loneliness and worklessness and food poverty and all that through healthcare. It is a very expensive, very ineffective way of trying to resolve these problems. So I don't think thinking of holistic support, that means I'm arguing doctors and nurses should do more. I'm arguing that doctors and nurses should be aware of the fact that there needs to be other support available for people. And maybe now, you know, given we can't recruit workforce, and given primary care is apparently awash with money but doesn't have people and no one wants to come and work, maybe that's a good way where some of the money could go. Maybe actually having someone giving debt advice or benefit advice or people addressing loneliness is actually going to be a better way of strengthening the whole ecosystem of support for this winter than saying 5,000 new GPs. We're not going to make them out of gingerbread, are we? So I do think thinking of healthcare as part of a wider ecosystem should liberate the healthcare system to an extent.
Okay, thank you very much. I'm afraid we need to draw the question and answer session to a close now because it's 13:29 by my clock and we promised to finish now. So apologies if we're unable to get around to everybody's questions, but thank you very, very much for feeding in. And thank you very much, Charlotte, for your talk and also for coping so well with the wide range of questions that you're asked with. So just to give you the final minute, is there anything you would like to say or any observations you'd like to make before we draw this afternoon to a close?
I feel like you've heard quite enough of me. I just want to thank you all again for inviting me, and also thank everybody on this call for the hard work you're doing, and get safely through the winter, and let's put some plans into place so that we don't have this kind of crisis every year. Thank you.
Thank you very much, Charlotte. Well, thank you for your talks for the lecture today. So on that note, we'll draw things to a close. So thank you all very much for participating this afternoon. It's been lovely to see you and to hear all your questions, and have a nice rest of the day, everybody. Thank you. Cheerio.